Good afternoon, and welcome to our series of webinars focused on bringing you information about COVID-19 related topics. The information in these weekly webinars is geared toward long-term care and skilled nursing facilities, but we encourage everyone who is interested to attend. Today, we will be wrapping up our discussion about long COVID in nursing homes. This week, continuing to focus on quality measures and pain. Everyone will be on mute, but if you have any questions, please enter them into the chat and we will address them at the end of the webinar. My name is Kathy Caudill. I'm a communications specialist with Quality Insights. And now I would like to introduce our guest today, Patty Austin. Patty is a quality improvement specialist at Quality Insights. She has been working in the skilled nursing arena for the past 29 years. After starting her career as a nursing assistant and leaving the front lines as a director of nursing, the variety of perspectives that Patty has enables her to see the big picture that helps nursing facilities create lasting change within their communities. Patty has been with Quality Insights since 2016, and she considers it a privilege to be able to interact with so many different facilities on a variety of topics each day. Patty, welcome, and thank you for joining us today to wrap up our series on long COVID in nursing homes. And if you're ready, you can go ahead and take it away.
Thanks so much, Kathy, and hi, everybody. It's nice to be here again with you today to talk about long COVID and its impact on our facilities. Many of you have most likely heard our first presentation on this syndrome and then the follow-up session that we had last week that focused on long COVID and its impact on falls. Today, we're going to take that another step and look at an additional high impact area. Our hope is that by focusing on these sometimes unanticipated outcomes of COVID, that we'll be better prepared to lessen the negative impact that they can bring. For those of you that may not have listened last week, let's quickly review what long COVID is. For those of you that were with us for the past 2 weeks, the next 3 minutes is going to be just a little bit of a review. Long COVID is much like COVID itself was when it first made its appearance. We knew it was there, but we didn't understand a whole lot about it. We weren't sure how it was transmitted or the best way to treat it, and we surely didn't know what to do when we were faced with an outbreak. When it comes to long COVID, we find ourselves in the same boat. We know that our population is at greater risk for developing this constellation of symptoms, but there is no test to confirm it. There's no standard definition of it, and there's no way for us to predict who's going to fall victim to it. We do know that some studies point to 32% of people 65 and older suffering with symptoms of long COVID after that initial COVID infection is resolved. And that number is almost double that of those who are younger than 65. As the medical community continues to learn more about this new wrinkle in the COVID cloth, we again find ourselves in a position to manage the risk that's now brought to our residents. If we take a very high level look at some of the symptoms that we see when we're thinking about long COVID, we can begin to set a course to navigate them in the best way that we're able. None of the symptoms that we're going to talk about are unique to long COVID, and indeed, they're the same things that we deal with on a daily basis. There are things like fatigue and sleep disturbance, shortness of breath, muscle pain, joint pain, issues surrounding cognition and concentration and attention, even language. These things are quite common in our world. So you might be wondering, why then do we need to spend time talking about long COVID at all? These are the things that we deal with every day, day in, day out. And you're right, they are the things that we deal with every single day. However, attention still needs to be given to this new subset of people so that we're addressing every possible avenue that we have to lessen the risk and promote our residents' highest level of function. One way to do that might be to view COVID through the lens of quality measures. The symptoms that we've mentioned can have a large impact on many quality measures. Putting a proactive plan in place allows us to be in the best position to mitigate unwanted outcomes. Last week, we took a look at falls and the impact that COVID had on them. And this week, we're going to discuss pain and the sweeping consequences that long COVID induced pain can have on many, many quality measures. Medical News Today speaks to a study that looked at 273,618 post-COVID patients and found that within 6 months of recovering from that initial infection, 13% experienced chest pain or throat pain. Another 12% experienced some other pain, things like headache or stomach ache, and 3% experienced myalgia or muscle aches. Those are some pretty big numbers. And because they are big numbers, many studies are underway to discover treatments for this particular long COVID symptom set. However, pain management is not yet standardized, and it's focused on the treatment of the symptoms themselves rather than long COVID. Multimodal approaches should be proposed that move past that purely pharmacological approach. Both physical therapy and psychological approaches might be highly beneficial. There is also some caution needed not to assume that a patient who's suffering with pain related to long COVID is automatically kind of put into that bucket of having fibromyalgia or neuropathic pain. And a case can also be made for avoiding opiates in most post-COVID pain syndromes. That's a discussion for you and your medical director or the attending physician. Again, no tests exist for long COVID, so it can be a long road to discovering the cause of pain, and only after all other possible causes are ruled out should long COVID be considered. We should also note that there is a predisposition of worsening chronic pain in some post-COVID patients. So those with current diagnoses of things like fibromyalgia have to be even more closely monitored. As a young nurse, one of my mentors told me that pain was sticky. Pain sticks to everything, and everything sticks to pain. The message that she was trying to impart was that pain doesn't live on an island, and that a patient with chronic pain might be expected to show decline in other areas. And that strikes me as kind of a vital concept when we consider long COVID. Pain can lead to things like sleep disturbance, depression, anxiety, and all of the complications that come with those things. These almost intangible areas can then turn right back around and prolong, maybe even worsen pain. So what can we do to lessen the impact? In addition to the medications that are chosen to treat post-COVID pain, things like physical therapy, meditation, acupuncture, and psychiatric support to address depression and anxiety could be helpful for you. So what does that mean for us? It means that pain has always been important and complicated in our setting, and it's now even more so. As we wade through the complexities of pain, it sometimes helps to kind of take a step back and keep it simple. So the first thing to remember is that you need to really attempt those non-pharmacologic approaches before you medicate when you're talking about mild pain. Intervening here with an effective non-pharmacologic program can prevent that pain from moving beyond mild into the moderate pain level. And eliminating pain isn't always possible. At times, we're going to have to settle for the goal of not allowing the pain to negatively impact activities of daily living, or to be what is the decision maker between going and enjoying bingo or staying in your room. This non-pharmacologic approach has been very underused in our setting for many years, but I would encourage you to dig a bit deeper in that area. Non-pharmacologic means far more than adding moist heat or providing rest periods. Something as simple as distraction can work wonders for mild pain. And it's going to be our job to find out what distraction looks like for our individual residents. Maybe something as simple as a book on tape or a puzzle to work on might work. The possibilities that we can uncover are as diverse as our census is, and uncovering them is going to serve you in many different ways. As a second step, when pain has moved from mild to moderate, please consider non-opioid agents first. That doesn't mean we throw those non-pharm interventions out the window, but maybe an anti-inflammatory along with that book on tape can prevent moderate pain from moving to that severe level. And finally, opioids are a measure of last resort. Short-acting opioids are always preferred over extended release opioids for chronic pain. And again, that is a discussion for you and the attending physician and the resident to engage in. Setting realistic expectations is going to be key in helping you as the caregiving team keep in line with the goals of the resident. It will be beneficial to help your residents understand that pain-free may not be realistic, and then to determine what level of pain is acceptable to them, and then work together to make that a reality. We would be missing a large part of the pain puzzle if we didn't consider some of the other areas that pain can impact, those areas that pain sticks to. Although pain is no longer a quality measure, many measures are impacted by residents who are experiencing pain. So let's take a look at some of those. Last week, we talked about falls. They too can be negatively impacted by pain. You might wonder how the two are connected. They don't naturally fall together, falls and pain. Although poorly understood, clinical observation suggests that pain, especially chronic pain, may undermine muscular function and joint integrity. It can also interfere with things like balance, mobility, and cognition, all of which accelerate functional decline. Even the fear of pain, when you're so worried and preoccupied with your pain level increasing, can lead to alterations in gait and further increase your risk of falling. Then, of course, we have all those functional QMs, things like percent of residents who have made improvement in function, percent of residents whose ability to move has worsened, and percent of residents whose need for help with ADLs has increased. It's really easy to see how pain can play a role in all of those areas. Even the fear of pain, again, can be enough to prevent a resident from performing up to their highest level of function, particularly if they feel that their pain won't be addressed. As these areas are impacted, we can then see how they might begin to experience a greater risk to the QM high-risk residents with pressure ulcers. First, we will have more residents who are classified as high risk because their ability to move independently is impacted. And then second, because their ability to move independently is impacted, they're going to be at greater risk for pressure ulcers. You can also see how actual pain might prevent a resident from ringing that call bell to go to the bathroom, leading to a loss of bladder control. That bladder control loss could then lead to a UTI, and we have yet another QM heard from. All of those areas can lead to symptoms of depression and then the weight loss that sometimes accompanies that. The anxiety caused by pain could also lead to medications being prescribed, and suddenly the resident is triggering for having an anxiolytic prescribed. So we can also see how many of those things might lead to a trip to the ER and even a rehospitalization. At the end of the day, other than vaccine measures, we've hit all of the QMs. That sounds pretty dramatic, and it can be dramatic. Your post-surgical resident in for a couple of weeks of therapy, gets COVID, develops long COVID with chronic pain. The next thing you know, she stops stressing herself because her muscles just hurt too badly. And instead of walking to therapy, she needs a ride. She stays in bed instead of going to activities because she finally just got comfortable and she thinks getting up might bring the pain back. That's the same reason that she's not going to ring the bell as quickly to go to the bathroom. 2 weeks into long COVID, she's back to her post-surgical baseline and all the gains she made in therapy have been lost. She's at 50% incontinence and now has a stage 2 in her coccyx, and she's lost 7 pounds. She just finished a psych consult to try to figure out what in the world's going on because her son is, of course, very worried. And guess what the doctor did? He prescribed Lexapro and Ativan PRN. So really, when you look at a simple scenario like that, it really isn't so far-fetched. Post-COVID patients, especially those with pre-existing pain issues, need to be routinely and aggressively evaluated for pain. We most likely have a pain assessment and pain protocols in place. However, the strength of these programs varies widely between facilities. Now is a super good time to evaluate what you're doing in your facility to manage resident pain and to see where your opportunities for improvement lie. Post-COVID pain or non-COVID related pain can have serious consequences when not treated appropriately. And I know that was a whole lot of information spoken very quickly, but I will turn it back to Kathy to see if we have any questions at this point.
All right, thank you, Patty. So I muted myself, right? Okay, good. In a minute, we will start the Q&A portion of this meeting. If you have any questions, you can enter them into the chat or the Q&A box. While we're waiting, I'd again like to remind everyone that we do these webinars relating to COVID-19 related topics in nursing homes every Wednesday at 2 p.m. We also host office hours live chats twice a week. And so if you are looking for one-on-one advice for your facility, you can pop in during our office hours and shoot us a message, and someone will be there to answer your questions. Those are every Tuesday at 8 a.m. and every Thursday at 2 p.m. You can find the links to those live chats and our webinars in the newsletter we send out each Friday called the Last Minute Lowdown. And if you would like to receive that newsletter but don't think you're on the mailing list, you can email me at caudill@qualityinsights.org and I will get you on that list. And I will drop my email in the chat shortly in case you did not catch that. And if you would also like a recording of this week's webinar, you can also send me an email. And right now, I'd look to see if there are any questions. All right, Patty, we have a question here. You mentioned non-pharmacologic pain interventions. We find those difficult to come up with. Do you have any suggestions?
That's a great question and not entirely unexpected. So non-pharm interventions can be difficult to be creative with. If you ask a person with chronic pain what helps their pain, chances are the reply that you're going to get is nothing, give me my medicine. And that can actually be a learned behavior developed to protect themselves from prolonged periods of untreated pain. The best way to combat that can be creating a sense of trust between you as the caregivers and your residents. Pain can be scary, especially for those people that have had bouts of untreated or ignored pain in the past. They, like most of us, will do whatever they can to avoid that happening again. So their natural tendency is just going to be to take the pill that they already know is going to help them. The goal of non-pharm intervention for mild pain is to distract the resident from focusing on the pain and give her mind another avenue to travel and her body a chance to relax. You might try alternative ways to determine what works for each particular resident. You're going to find that you're going to get different answers if you pose the questions in different ways. If you say something like, what helped you relax after a long day at work? Or when you were really stressed at home, what did you do to de-stress? Those answers are going to be very different than if you would say, hey, what can we do to take your mind off your pain? Or one of my favorite questions to ask is, tell me one thing that always makes you laugh. We know that laughter reduces endorphins, and those endorphins naturally reduce the perception of pain. So Those types of personal narrative questions are really best asked as part of a conversation rather than in an interview format. Residents are then going to be more candid, and your chance of finding a true intervention will increase. Families are also very helpful in this area, and it can lead to some pretty fun conversations and help to build the trust that you're looking for. Sometimes the nurse is not the right person for that conversation initially. Consider people like social service staff or activities staff to get those conversations started. And then once the ball is rolling, the clinical staff can follow up. Another important thing is for the resident to realize that a non-pharmacological approach does not mean that medicine is not going to be available to them if they need it. And that goes right back to building trust. If, let's say you walk into Mary's room and she's rating her pain at 5, and you engage in a non-pharmacological approach with a promise that you'll return in 15 minutes to reassess, and then here's the key point, you actually come back in 15 minutes. In this particular case, it really does need to be 15 minutes, not 18 minutes. If you said 15 until you build that trust, if you come in at 18 minutes, you're late, and that trust is not going to be enhanced. So when you go back in after 15 minutes, maybe Mary's pain's still a 5 and she requests medication. But your goal is not necessarily for the first time an intervention is attempted to have it be successful. Your goal is to help your resident understand that they have options aside from that medication, and that you're their partner in the process of reducing pain. That should be a very individualized process. Remember that 15 minutes is an awful long time to be in pain. In some cases, you might need to start slower and begin with 5 minutes while you prep the medication and build up to longer and longer times attempting that non-pharm intervention. We could go on and on with this topic, but I know that we are moving right through our time, so I'm going to turn it right back over to Kathy.
All right, and I did not see any more questions, so I'm going to go ahead and wrap us up.
Okay, thank you.
If you want to contact Patty directly, you can reach her at 1-800-642-8686 and enter extension 7633. You can also email her at paustin@qualityinsights.org, and I put her email there in the chat, as well as my own. And you can check out our other interviews by visiting qualityinsights.org/QIN/multimedia. Thank you all for joining us today. And Patty, thank you for joining us today.
See everybody next time.
Thank you.